Beckwith-Wiedemann syndrome, it affects 1 in 13,700 live babies. Now, the most striking factor of Beckwith-Wiedemann syndrome is macroglossia. That is the most distinguishing and striking factor in Beckwith-Wiedemann syndrome. The other one is umbilical hernia or omphalocele. 42 or nearly half of them has umbilical hernia or the anterior abdominal wall defects that include umbilical hernia or omphalocele. Then there is a higher propensity towards macroglossia. There is polyhydramnios and macrosomia or large for gestational age babies. 1/3 of them would be large for gestational age babies. Now, Beckwith-Wiedemann syndrome also is known for having segmental hypergrowth or overgrowth, hypertrophy, which means part of the body part of the body has overgrowth problem, as in half of the body will be overgrowing, so there will be hemi-hypertrophy, or there are conditions in which only leg will have an overgrowth. So those kind of segmental overgrowth is more commonly associated with Beckwith-Wiedemann syndrome. Now, what about Beckwith-Wiedemann syndrome? What other features will be there? So there can be organomegaly, that includes nephromegaly, which is like renal abnormality, and hepatomegaly, cardiomegaly, and these findings are seen in around 1/6 of the babies with Beckwith-Wiedemann syndrome. There can be placental tumors or placental abnormalities, including PMD. PMD is placental mesenchymal dysplasia. There can be intracardiac rhabdomyomas, or it can be abnormalities with corpus callosum, including partial or complete agenesis of corpus callosum. So all these could be associated with Beckwith-Wiedemann syndrome. So just to give you a hint, this is the omphalocele. So you can see this is the abdominal wall, and this entire part is a defect. Through the defect, the content, this is the liver, this is bowel, so it has been herniated out. So that is an omphalocele. And this is cardiomegaly, where the heart is enlarged and occupying a major portion of the thorax. This is placental mesenchymal dysplasia, where you can see this area is clearly dysplastic, and this is the normal placenta and this is the abnormal placenta. Agenesis of corpus callosum is evident by having a colpocephalic, and this is the 3-line sign. So I will show again. This is the 3-line sign, and this is the colpocephalic ventricle. Rhabdomyoma, here you can see this is the rhabdomyoma. Again, this white echogenic area that you can see in the ventricular wall, that is the rhabdomyoma. Moving on, macroglossia or the enlarged tongue, that is seen in 1/6 of the cases. Coming to the genetic basis of or genetic cause behind Beckwith-Wiedemann syndrome, it is because of the involvement of 11p15-5 region, and this is otherwise can be because of imprinting disorders. Well, imprinting disorders is errors in the genomic imprinting. Now, when there is a imprinting center, one gain of methylation will be there, and increased expression of IGF-2. IGF-2 is a growth promoting factor. And what about imprinting center 2 is loss of methylation, and there is a decreased expression of CDKN1, which is another tumor suppressor marker. So either of this, it's all like methylation abnormalities. So it can be an imprinting center 1 abnormality or IC2 or imprinting center 2 abnormality involving the 11p15 area, and mutations in CDKN1C gene, which is specifically the tumor suppressor gene, also can attribute to Beckwith-Wiedemann syndrome. What about his inheritance? It is up to 85% of the time it is a sporadic condition, but rarely it can be it can be inherited as autosomal dominant condition as well. The third common type of the inheritance is uniparental disomy. What about each each abnormality, phenotypic, what each genetic abnormality, what phenotypic abnormality is common. Well, when we look at hypomethylation, abdominal wall defects involving the omphalocele and umbilical hernia, that is more common, along with macrosomia. As far as hypermethylation is concerned, macroglossia is more common with organomegaly. So, when it is hypomethylation, it is abdominal wall defect and macrosomia. What about hypermethylation? It will be macroglossia as well as organomegaly. And this is paternal uniparental disomy, in that only macrosomia will be seen. So, how do we find this? Once you suspect such a scenario, such a syndrome, how do you find them? How do you diagnose them? Well, you can do an amniocentesis, take the amniocytes, and you can do methylation testing. That is the first line test. Now, if you don't get an answer in methylation testing, methylation should give an answer in case of this as well as this. So, if it is not seen, then the possibility is either it could be a mutation or it could be a uniparental disomy. So, what you can do, you can test for those two. How do you do that? You can do a UPD testing and CDKN1C sequencing. CDKN1C is a gene sequencing, so that can be found out in holosome sequencing. So, first you can do a methylation test. Along with that, CMA, chromosomal microarray, you can do, and if you don't find an answer in that, then UPD testing and CDKN1C sequencing or holosome sequencing can be done. Coming to prognosis, it is variable. It depends on the severity of the syndromes. There is 7% risk of tumor in the lifetime, increased risk of Wilms tumor, hepatoblastoma, neuroblastoma, all these are childhood cancers, and developmental and learning difficulties could be there. And what about long term monitoring? This patient has to be on lifelong monitoring for development of cancers as well as potential complications.